Welcome to my YouTube channel. Thanks very much for the subscriptions. For those ones who subscribe, those ones who have not yet subscribed, please do one thing: subscribe, put on a notification, and we continue to learn. Earlier on, I made a video about the general overview and classification of antibacterial agents and their modes of action and their targets of action. Today, I'm going to start breaking them, going to deep pharmacology of each category of these antibacterial agents, starting with cell wall synthesis inhibitors. These ones, they convey their action on the bacteria by inhibiting the synthesis of its cell wall. We know bacteria, they have a cell wall which is not in humans, and they have some certain components in their cell walls, and these components you can never find them anywhere else, and these are the peptidoglycan. This layer is made up of glycan units which are cross-linked by peptide linkages, and the enzymes involved in this action are what we call penicillin binding proteins. So these drugs, the beta-lactams, and the most important drug among this category are the penicillins. They have a beta-lactam ring. That's why we call them beta-lactams, as we are going to see the structure of these drugs. So what do? This ring interrupts the final stage of cell wall synthesis by inhibiting elongation of this peptidoglycan layer. How? We are going to see in the mechanism of action. So, looking at the structure of our penicillins. So, what you're seeing here, this is what we're referring to as the beta-lactam ring. This one here is the beta-lactam ring, which gives the name, the general name to the class of drugs being called beta-lactams. So when we add this part and this amino part, it forms what we call 6-amino penicillinic acid. Then on top of the beta-lactam ring and this acid and amino group, we have the R group here. So this R group here determines 1. Stability to what? Enzymatic action and acid hydrolysis. Then another thing, it affects spectrum. So it depends on the R group that the drug is going to have a narrow spectrum or a broad spectrum. It depends on the R group, the drug is going to be susceptible to hydrolysis by the acid or hydrolysis by the bacterial enzymes. Then here, where we see these bonds here, this is the site where we expect hydrolysis by bacterial penicillinases or acid hydrolysis. So this is the structure of our drugs, the general structure of our beta-lactam drugs, including cephalosporins and penicillins. But right now we are looking at penicillins specifically. So when we look at the classification of penicillins, we have the natural penicillins and those ones which are synthetic penicillins. So naturally occurring penicillins, they are divided into two. We have those ones which are acid labile and those ones which are acid resistant. Among those ones which are acid labile, we have penicillin G, that is benzyl penicillin. We have procaine penicillin G. We have benzathine penicillin G. Then we have those ones which are acid resistant, where we have penicillin V, that is phenoxy penicillin. So when we go to semi-synthetic penicillins, they are further divided into 3 categories. We have penicillinase resistant, you have beta-lactamase inhibitors, and the expanded spectrum. So further subdividing the semi-synthetic penicillins, we said we have further subdivisions, which are three. We have penicillinase resistant, extended spectrum, and the beta-lactamase inhibitors. Among penicillinase resistant, we have methicillin, cloxacillin, and dicloxacillin. Extended spectrum, they are further divided into three depending on the chemical component. We have aminopenicillins, we have carboxypenicillins, and the uridopenicillins. Among the aminopenicillins, there is ampicillin, there is vancomycin, and amoxicillin. The carboxypenicillin, we have decapenicillin, and the uridopenicillins, we have peracin and the mesorocillin. Then, when you look at the beta-lactamase inhibitors, these inhibit the bacterial beta-lactamase enzymes. We have clavulanic acid, we have sulbactam, and the tazobactam. When you take them, how do they combat the bacteria? So the mode of action of these drugs, they are going to go and bind on the enzymes which we refer to as the penicillin binding proteins. These enzymes are the ones responsible for the elongation process of the peptidoglycan layer, of cross-linking the glycans with peptide bonds. So once these drugs bind there, once they bind on these proteins, it means that there is no elongation of this layer, exposing the osmotically unstable cell wall. Osmotically less stable membrane which is going to be exposed is going to undergo what we call lysis, either by osmotic pressure or by autolysin activation. So this implies that our penicillins are bactericidal. We have two categories of drugs. You have those ones which are bacteriostatic and those ones which are bactericidal. So those ones which are bactericidal, it means that they lead to the death of the bacteria. Those which are bacteriostatic, they just make the bacteria dormant, but they don't kill the bacteria. But in this case, our penicillins are bactericidal because they are going to lead to lysis of the bacteria, either by autolysin activation or by osmotic pharmacokinetics of these drugs, the penicillins. And under pharmacokinetics, we are going to be looking at absorption of the drug, distribution of the drug, and elimination of the drug. So these drugs, when we look at absorption part, they vary. Absorption varies when they are taken orally, and their absorption is affected by food. That's why we should take penicillins 2 hours before or after taking a meal. So we have those ones which are not absorbed at all when taken orally. Examples of carpenicillin, ticagrelor. Then we have those ones which are moderately absorbed while taken orally, where we have benzyl penicillin, where we have ampicillin and cloxacillin. Then we have those ones which are highly absorbed when taken orally, where we have our phenoxypenicillin, PENV, where we have our vancomycin. So this affects the route of administration of the ampicillins. That's why normally benzyl penicillin or PENG, we give it intramuscular, and you find that phenoxypenicillin or PENV, we give it orally due to absorption. Distribution. They are well distributed among body tissues. You don't have ability to cross the blood-brain barrier. Only in the case of meningitis, when the meninges are highly inflamed, we increase the IV dose of these penicillins and we use it to treat meningitis. When you look at drug elimination, eliminated by via kidneys, via breast milk, and via the fecal matter. Then the dosage should be adjusted in patients with severe renal failure. Drug elimination is affected by probenicid. So when probenicid is taken, when the patient has taken a penicillin, it's going to double the amount of penicillin in the body. Why? Because no elimination is going to take place. The drug has a high index window, making it more safe. So semi-synthetic penicillins and some of their indications. What are their targets? What are their spectrum? When we look at penicillin V, that's phenoxypenicillin, we use it on mild streptococcal and pneumococcal infections. Oxacillin and cloxacillin, we use them on Staphylococcus aureus and Staphylococcus epidermidis. Then ampicillin and amoxicillin, they are spectrum extended to gram-negative bacilli. Then carbapenicillin, we use it on UTI, mostly caused by Pseudomonas aeruginosa. Then mesoracillin and piperacin, we use it to Pseudomonas infections and Klebsiella infections. In treating pneumonia, we can use them in treating upper respiratory tract infections such as diphtheria. We can use it to treat urinary tract infections. We can use it to treat typhoid. We can use it to treat various conditions, various bacterial conditions. So, the drug interactions. How do these penicillins interact with the other drugs? Since they are cell synthesis inhibitors, they are going to break down the bacterial cell wall, making it easier for other drugs which do not have ability to break down the cell wall to enter the bacteria, such as aminoglycosides. They can now enter very well, and the combination of penicillin and aminoglycosides gives us a synergy where the effect is additive. With contraceptives, penicillins lower the efficacy of contraceptives. How? By impairing enterohepatic saturation. So by impairing enterohepatic saturation, we are going to see the efficacy of contraceptives being reduced. They will fail to work. So don't take contraceptives when you're taking penicillins. Then the effect of warfarin. Penicillin on warfarin, they increase the action of warfarin. Since warfarin is an anticoagulant, what do? They are going to go inside and they distort the enteroflora, what is going to happen next? These flora are the one responsible for the production of vitamin K, and another thing is activation of cytochrome P450, which is going to increase the breakdown of these drugs, warfarin. And then our penicillins have been now phased out due to increased resistances. So how do these resistances come about? Various ways, and one of the ways is inactivation of the drug by bacterial beta-lactamase enzymes. So these bacteria, they produce these beta-lactamase enzymes. So those enzymes are going to come and break our beta-lactam ring. So another way or another method of resistance can be via efflux pumps. So some bacteria have efflux pumps which keep on pumping the drug outside the bacteria before it could be effective. Another way is modification of the protein binding, penicillin binding proteins via mutations. So this one can imply that the penicillin has nowhere to bind since the binding sites have been modified via mutations. Then another thing is when the drug cannot penetrate the bacteria. We see the case in the gram-negative bacteria where they have a lipopolysaccharide layer which is impenetrable. Then when we look at gram-positive bacteria, they lack pollins. So it becomes hard for certain drugs to cross, for certain penicillins to cross. So looking at the adverse reactions of the penicillins, they are remarkably non-toxic as drugs because they have a wide therapeutic index. So they are relatively safe. But some of the adverse effects, well, we have one, hypersensitivity reactions due to penicilloic acid, which is a metabolite of penicillin. So these ones range from skin rash to anaphylactic shock. They include fever, nephritis, pruritus, urticaria, and joint swelling. Then when we look at those ones which are related to methicillin, there is interstitial nephritis, while nafcillin causes neutropenia. Instance of allergic reaction in small children is negligible. So when you look at the two, we have GIT disturbances due to overgrowth of gram-positive organisms or by the direct irritation. We have nausea, vomiting, we have diarrhea. So when there is also pseudomembranous colitis, which is inflammation of the colon. So when we continue looking at the adverse effects, we are going to look at local irritation. This can include pain at the injection site, then thrombophlebitis. Neurotoxicity, which can include mental confusion, muscular twitching, convulsions, and coma. And bleeding can occur due to interference of platelet function. So when the penicillins are given via the intrathecal route, though they are not recommended, they can lead to arachnoiditis, degenerative changes in the spinal cord. Then accidental IV procaine injection can lead to CNS stimulation, hallucinations, and convulsions.